Your chest. Can you pick your chin up and look at the ceiling? Can you bring your chin over to your shoulder? Chin over to this shoulder, and bring your ear to this shoulder, and ear to that shoulder. So there's active range of motion of the neck. So resisted range of motion. So look up at the ceiling, put my hand here to give some counter force. Don't let me push you forward. Put your chin down, hand in the back, pushing on the forehead. Good. Bring your ear over towards your left shoulder. Don't let me push you over. Ear towards your other shoulder. Don't let me push you back. Good. Bring your chin toward this side. Don't let me push you away. Chin over here. Don't let me push you away. Okay? So those are our active and resisted ranges of motion. Okay? So after that, then there was the axial loading. Is that the next one that's on the list?
Yes. Yeah.
Okay. So axial load is basically they're standing there and you push on their head. If they've got a disc problem, it could make it pooch more and give you stuff going down the arm. You can also do this with a little bit of extension, and as you close that down, again, it may close down the neuroforamen on the side where you have a disc herniation. Yeah. So the next one is Spurling's on the list. Okay. So Spurling's maneuver, we're going to do it for if he had thoracic outlet on the left side. So I will grab his arm and bring it back into extension and check his pulse here to make sure that he's got a radial pulse here.
Head down.
Actually, and then, so I'm going to have him look toward his left shoulder, which usually everything is fine. And then you have him look away to the other shoulder, and if the pulses go away, that means that you just cinch down, and so now the pulse goes away. So that is an abnormal Spurling's maneuver.
Have them look away, is that what you're saying?
So when you look away, you're putting tension on all these things on this side, and that's what makes your pulse go away.
That's crazy.
Okay?
What if they fall asleep like that and then they like their arm falls off the next morning?
So there's a couple of things that, you know, there's like alcoholics can get a palsy because they fall asleep in weird places and they fall so deep asleep that you can get stuff like that.
Oh my god.
So the next thing was it the palpation of the shoulder that's on the list?
No, we have neurovascular.
Okay, so sensation C5, C6, C7, 8, T1, reflexes, biceps, triceps, brachioradialis, which we'll go over when we got the reflex hammer. And so when we're doing strength, that's kind of what we're doing with the shoulder. So we'll put those things when we go to that one. So
Then we have shoulder inspection.
So inspection, you look at them from behind. So you look at scapular station. Is the scapula up, out, over, got a scoliosis, that kind of stuff, just to look for symmetry. In general, the dominant shoulder is usually about a little bit lower than the non-dominant. So if they have an AC separation, you're going to look for a bump, or you may see some bruising ecchymosis. If they have a dislocation, they may have a big bump out here. But also if you have a fracture, you may have a big bump out there. So that's what you're looking for in inspection. Then we palpate.
Anteriorly.
Start anteriorly. So anteriorly, you start at the angle of Louis, and you got your sternoclavicular joint, which is right there. And as you march out the clavicle, it kind of has an S. So as you're coming back out to the very end, you'll get to the end of the clavicle where your acromion is. So right there is your AC joint, clavicle, acromion. So as you have your acromion, then we'll kind of spin you this way. And then you've got your scapular spine posteriorly back through here. So once I got them here, I'll check levator scapulae, which goes right off the top of the scapula, kind of diagonally up toward the neck. You got your supraspinatus fossa, your infraspinatus fossa, so above and below the spine. And then you got your posterior joint line, which should be right along with your acromion posteriorly, back and through there. And then you can go anteriorly, so you got that acromion. As you come across forward, right lined up should be long head of biceps. And if you can't find that, you keep your finger there, and can you bring your arm up here like that, and you'll feel it move underneath of your finger, and then back down. So just medial to that is going to be your anterior joint line. And then a little bit more medial to that is the knob of your coracoid, which hurts when anybody pushes on it.
I think so.
So did we palpate everything that we had on the list?
SV joint, clavicle, AC joint, coronary line. Can you
spell out anterior again?
So you go anterior, you go acromion, long head of biceps, and then kind of a little medial. It,
Yeah,
you know,
it kinda comes
if
in
you
a little
go,
bit.
look at the border of your anterior delt, that's kind of where it should be, in that general area.
Maybe a little younger.
Okay.
Just 'cause-
So what's next on the list?
Then we have functional testing, active, resistant, and passive for abduction.
Oh, I didn't mean biceps, I meant
Okay,
interior.
so active range of motion, I start looking from behind. And so I have them take their arms from side and slowly bring it up over the top of the head. This is one we had Jeremy do for about a half an hour looking at his scapula. I left my phone because I was afraid it was going to rain. And bringing it back down to see, again, is there winging of the scapula. If they have a rotator cuff tear, this is also where you get your drop arm test, because as you get them up to here, and you say slowly bring it down, as they bring it down, they also go boom, because the supraspinatus, usually infraspinatus maybe, will give you loss of eccentric control and it'll drop. So you already got one of your provocative tests there. So that's abduction, and then you have them do forward flexion. So this is the same as Neer's test. So you have them bring them up here, and if they start making faces when their arm gets to 90 degrees of forward flexion, that's a positive Neer's. As you go up into that direction,
Posterior.
anterior impingement. Okay. So we had active, so the other active range of motions are internal rotation and external rotation, so elbows in, and how far out can you bring, and you're looking from symmetry from side to side. And then internal rotation, turn around, and can you take this hand behind your back and go up as high as you can go? And there, and then bring it down, and the other side.
Yeah. Okay, you're.
And usually the dominant, this is internal rotation. Internally rotated to get back here. So people who lack this, they like can't get their wallet out of their back, or ladies can't undo their bra in the back because they can't get there.
Always something.
What were you saying?
Usually go higher because.
What were you saying about the dominant hand?
The dominant hand, usually you can go up a little bit higher than you can in internal rotation than the non-dominant.
Yeah, you can scratch your neck.
I can put on my own sunscreen.
That goes along with their hypermobility.
Once again, Emily's crazy.
It all goes back to that. So that was all the
Okay,
active range of
stretch
motions,
my
correct?
All that swinging.
Supraspinatus. I didn't.
But that's resisted range of motion.
Oh, yeah.
So if you look at that little grid, under active, there should be abduction, forward flexion, internal and external rotation. So then the next one are the resisted, so you're looking at strength. And so my brain goes to, you can do a screening exam so you can go forward flexion like this, and then don't let me push you down like that, and so you're making sure that it's not asymmetric. The other thing is you can look at the scapula at that time. So, flip this around. So if his scapula is weak here as I'm pushing this down, sometimes this'll pooch up like this, and it'll look, so I can voluntarily do it. So as you're doing this, you see the scapula kind of pop out like this, which again tells you that he may have anterior impingement, but you got to work on the scapular stability in there. So that was resisted forward flexion. Then we do, actually, side. So resisted external rotation, which is infraspinatus and teres minor. Push out against me. So that's external rotation. Cross your hands, squeeze them together. Internal rotation. And then supraspinatus, forward flexion, 45 degrees, thumbs down, don't let me push you down. And remember that the supraspinatus is about the size of your finger, so I have a big advantage. So this is not one of those, you kind of do one of those because it'll hurt. So, so we did internal, external, supraspinatus, forward flexion. I think that's all.
And then passive.
The abduction was what we, And then the passive one is with internal and external rotation, and that's the one when we do when they're laying down and we're doing Fowler's relocation. So again, imagine that he's laying down, and then I'll bring this back to see how far in external rotation he goes. So this is 0, that's 90, and if that's 0, then we go internal rotation, which is about 30, 35 degrees. But doing it on the table helps you take the scapula and the thoracic spine out, so you're not